1.5 to 2.5 centimeter with main pancreatic duct communication. So most probably it is IPMN. If it is IPMN, whether it can be main duct or branch duct IPMN. If it is 1.5 to 1.9 centimeter cyst, then go for re-imaging once in every year for 5 years. If it is stable, then stop the re-imaging. If there is any interval growth, go for US guided FNAC. If it is cyst is more than 2 to 2.5 centimeter, go for re-imaging every 6 months, because threshold growth is more than 2 centimeters. So if it is more than 2 centimeters, do re-imaging every 6 months, then every 1 year, then every 2 years. If it is stable, stop the re-imaging. If there is any interval growth, go for directly US guided FNAC. And if there is no main pancreatic communication, that is miscellaneous cystic neoplasms, you can go for two approaches. Usually AGA guidelines and IPA guidelines says that directly go for US guided FNAC and operate, and European guidelines says go for re-imaging every 6 months. Then if it is stable, stop the investigation. If there is any interval growth, go for US guided FNAC. If it is cyst is more than 2.5 centimeter, if it is serous cystic neoplasm, based on whether it is asymptomatic or symptomatic. If it is asymptomatic, just re-imaging or observe. If it is symptomatic, go for a resection if patient is fit. If there is any low risk features, like if there is no mural nodule, no cyst wall thickening, no calcifications, if there is no complex cyst, then go for re-imaging. If there is any high risk feature, go for US guided FNAC. So coming to telling briefly about the pancreatic head adenocarcinoma, usually they present with abdominal pain, which is continuous dull aching type pain radiating to back. Write down that CECT abdomen pancreatic protocol is the imaging of choice. In CECT abdomen, usually we have to take thinnest sections possible. Usually preferably 64 multilateral CT scan with 0.1 mm to 3 mm cut sections. And we have to use neutral contrast, not the oral positive contrast. Neutral contrast like water or mannitol. So if you give oral positive contrast, it will interfere with the maximum projection value. And intravenous contrast should be high iodine content with injection rate of 3 to 5 ml per second. In CT, we have to see the morphology of the tumor, whether it is hypoattenuating or isoattenuating, what is the size, location, what is the relation with the pancreatic duct, and is there any biliary cutoff is there or not, and then we see whether there is any arterial involvement is there or not with SMA, celiac axis, CHA, and we have to see arterial variant anatomy. Sometimes right hepatic artery directly arises from SMA. We may miss and we may resect the right hepatic artery. It may go for hepatic necrosis. So always we have to see the variant arterial anatomy. And then we have to see the venous anatomy, like main portal vein contact, SME contact, and is there any collaterals or thrombosis in the veins. And then we have to rule out the metastasis like ascites, omental nodule, lymph nodes, any liver lesions are there or not. Coming to second investigation, EUS. EUS is done, it is not a routine investigation, it is done only to take the FNAC from the pancreatic lesions. If the pancreatic lesion is resectable, biopsy is not necessary. If it is not resectable, or if it is borderline resectable, or if you are planning for neoadjuvant therapy, then only US guided FNAC will be taken. PET CT is not a substitute for a high quality contrast CT scan, because contrast CT scan will provide all the details about the arterial, venous anatomy and everything. So PET CT is only indicated if it is a borderline resectable disease or very markedly elevated CA19 levels, large primary tumor, large regional lymph nodes, or patient is very symptomatic with significant weight loss. These patients will advise for PET CT scan. And before going for a surgical open impulse PD, we will do staging laparoscopy usually when the patient is pancreatic body tail tumors, or prior to neoadjuvant therapy, extreme pain, extreme weight loss, or significant regional lymph nodes with large primary tumors. In these cases, we will do the staging laparoscopy. In staging laparoscopy also, we will give the peritoneal washing, and we will send the peritoneal washing for cytology. If cytology is positive, then it is considered as metastatic. In biopsy, as I already told, pathological diagnosis is not required before a resection if it is resectable tumor. If it is not resectable, or if you are planning neoadjuvant therapy, then we go for US guided FNAC over CT guided FNAC, because CT guided FNAC percutaneous approach is associated with high risk of peritoneal CD. And biochemically we will see CA99 levels. It doesn't necessarily always indicate the cancer or metastatic. We have to rule out the cholangitis first, because in cholangitis there is high levels of CA99. So first we have to drain the biliary system. That is anatomical criteria of resection. Second is biological consideration. If it biological serum CA99 levels is more than 500 or extensive regional lymph nodes, it is also considered as borderline resectable. And conditional is if the patient performance status is more than 2 or more than 2, the patient is unfit for surgery. In borderline resectable, we will go for neoadjuvant chemoradiation. Usually, we will prefer the FOLFIRINOX regimen or gemcitabine paclitaxel regimen. In FOLFIRINOX regimen, usually it is based on the Prodigy trial, and gemcitabine paclitaxel is based on the Prodigy 24 trial. And RT dosing will be in between 36 to 54 gray in 1.8 to 2 fractions. This is the case we have operated for ampullary adenocarcinoma. After resection specimen this one. So this shows the CBD transaction margin, common hepatic artery, gastroduodenal artery, SME and portal vein. This is the SMEA margin, uncinate process cleared. This is the IVC, this is the gonadal vein, and this is the pancreatic transaction margin. And coming to the reconstruction, there are two types of reconstruction. One is pancreatico-jejunostomy, one is pancreatico-gastrostomy. There are different methods of end-to side or end-to side methods. If you compare the pancreatico-jejunostomy and pancreatico-gastrostomy, complications are almost similar based on the pre-panc randomized control trial and meta-analysis, except pancreatico-gastrostomy is associated with high levels of post-pancreatic hemorrhage, because that pancreas will be exposed to acidic environment in the stomach, so there will be high risk of PPH. Otherwise, all the complications are equal between the pancreatico-jejunostomy and gastrostomy. Coming to complications, the three major complications are pancreatic fistula, hemorrhage, and delayed gastric emptying following ripples. Which patients will develop a POPF? It is based on the modified fistula risk score. It's based on the gland texture of the gland, whether it is firm or soft. If it is soft gland, or if it is ampullary tumor, duodenal or cystic islet cell tumor with pancreatic diameter less than 1 mm, with intraoperative blood loss more than 1 liter, these are the high risk features for fistula development. International study group on pancreatic surgery, they have graded the POPF into 3 grades: biochemically grade B and grade C POPF. If there is only biochemically increased amylase levels without any organ failure or infection, then it is called biochemical leak. If it is persistent drainage for more than 3 weeks with associated, whether we have done any percutaneous intervention or endoscopic intervention, that is grade B. If it is associated with any organ failure, or if you have done any re-laparotomy or angiography, it is grade C POPF. Coming to post-pancreatic hemorrhage, it will be classified based on the time of onset, location, and severity. If it is less than 24 hours from the surgery, it is called early bleed. Most of the times it is due to technical failures. Late bleed will be more than 24 hours after surgery, and it can be intraluminal or extraluminal. If it is based on severity, if HB trough is less than 3 grams per DL, it is called mild leak, mild hemorrhage. If it is more than 3 grams per DL, it is severe. So based on that, it will be divided into grade A, B, C. If it is early mild bleed, there will be no clinical impairment. We can go for just observation. If it is grade B, like early severe bleed or late mild bleed, it can be life-threatening. So we have to go for CT scan, angiography, or if it is intraluminal, go for endoscopy. If required, surgical intervention. Grade C is late severe bleed. It is most commonly due to POPF, that pancreatic fistula eroding into the blood vessels. So in this, it is always life-threatening. Always you do CT angiography. If it is arterial bleed, embolize. If it is venous bleed, or if you are not localizing with the CT scan, directly do re-laparotomy. So there can be sentinel bleed, like if there any intermittent or obvious hemorrhage from Ryle's tube or drains or hematemesis and melena with HB trough of more than 1.5 gram per DL with spontaneous stopping of the bleeding. It is always most dangerous because it will be followed by the severe hemorrhage with which it can be life-threatening. If the patient has sentinel bleed, always evaluate with the CT angiography. Okay, if there is any bleed, do angioembolization. These are already discussed about early PPH management and late PPH management. Coming to delayed gastric emptying, it can be graded into 3 grades. Grade A is if the Ryle's tube is required for more than 7 days 4 to 7 days, or if you remove and reinsert after 3 days, there is unable to tolerate the solid liquid diet by 7 days. Grade B is up to 14 days. Grade C is up to 21 days. So it depends upon the in these cases we will insert the rail tube. In BC we have to give prokinetic drugs. So coming to one case scenario we have done 2 days back. This is a 19-year girl presented with epigastric pain radiating into back for 6 months with 3 episodes of bilious vomiting 2 days back. And we have evaluated the CEC abdomen pancreatic protocol and EUS. CT was showing homogeneous solid hypoechoic lesion in the body of the pancreas measuring around 3.4 to 3 centimeters just to the left of the SME portal vein with no other lesion elsewhere, and the posterior lesion was very close to splenic vein. It is abutting the splenic vein with no regional lymph nodes, and the MPD was not seen, and pancreas is very soft and lobulated.
C-axis, splenic artery, gastric artery, splenic artery, common hepatic artery. We have removed this common hepatic artery now. These are portal vein. We have made the SME and portal vein tunnel, and we have mobilized the total pancreas from the retroperitoneum by 8 min-hour, and
this is a final video.
so the renal cavity entered, lessers have opened.